Hello, everyone. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. It's such a great pleasure to have you all attending this webinar, Bridging the Medical Technology Gap, the impact of new technology on diabetes management. So next slide, please. We are the National Center for Health in Public Housing. We are funded by HRSA to provide training and technical assistance to all community health centers across the nation. In particularly, we work very closely with health centers located in or immediately accessible to public housing. Next slide, please. If you are not familiar with the health public housing primary care program, according to UDS data, the most recent data from 2021, there are over 1,300 community health centers providing services to over 30 million patients. 458 of these community health centers reported to be in or immediately accessible to public housing. And in the same year, they provided services to 5.7 million patients. 108 of these health centers are public housing primary care grantees. They receive funds from HRSA to provide services to public housing residents, and they serve over 900,000 patients in 2021. Next slide, please. In regards to public housing demographics, there are over 1.5 million people living in public housing. According to the most recent HUD data, this is 2023 data, 38% of the household reported to have at least one person with a disability. In regards to the ethnicity and race, 52% are white, 43% are African American, and 46% are Latino. 19% of the household report to have at least one person who is over the age of 65, and 36% of them are children, and 32% of their household are female-headed with children. Next slide, please. A recent study from HUD and the Center for Disease Control and Prevention, and these numbers have been updated recently. Diabetes is a priority for both federal organizations, HUD and HRSA. And according to the most recent data, HUD-assisted adults, over 17% of those HUD-assisted adults have diabetes, and there are other chronic medical conditions also affecting those HUD-assisted adults and are somehow related to diabetes. 71% are considered either overweight or obese, and the most recent data in regards to smoking, for instance, over 33% of those living in public housing or any of those HUD-assisted programs are current smokers. Next slide, please. So it's for us such a great pleasure to introduce our panelists for today's webinar. We have Dr. Eric Johnson, who is a professor at the University of North Dakota School of Medicine and Health Sciences in the Department of Family and Community Medicine and the Department of Education Resources, where he is the Director of Interprofessional Education and the Medical Director of the Physician Assistant Program. He also serves as the Assistant Medical Director for the Diabetes Center at Altru Health System in Grand Forks, North Dakota. A graduate of the University of Nebraska Medical Center, Dr. Johnson completed his residency in family medicine at the University of North Dakota Fargo program and is board certified in family medicine. As well, Dr. Johnson is a member of the American Diabetes Association Professional Practice Committee, past chair of the American Diabetes Association Primary Care Advisory Group, president of the American Diabetes Association North Dakota affiliate, and past co-chair of the American Diabetes Association Chronic Disease Prevention and Management Interest Group. Dr. Johnson has publications in the areas of diabetes, tobacco-related disease, interprofessional education, liver disease, diabetic neuropathy, diabetic eye disease, and cardiovascular disease. Dr. Johnson also has strong interest in team-based and technology management of diabetes. Dr. Johnson also has type 1 diabetes. In his spare time, he enjoys baseball, music, cross-country skiing, golfing, and spending time with his family. Dr. Johnson, good afternoon.
Good afternoon, Jose. Thank you very much for that kind introduction. I'll go ahead and get my screen shared here. And we'll go ahead and get started. So thank you again, everyone. Today we'll be talking about the impact of new technology on diabetes management and some of the gaps that we're actually seeing with this as it becomes more in play and more implemented. I do have a couple of minor disclosures. One, as Jose noted, I do have type 1 diabetes, and I do want to share that I have used many of these devices, but I am not promoting any particular device, and I don't have any other disclosures. Our objectives are as such that at the end of this webinar, participants will be able to discuss blood glucose monitoring devices, compare insulin delivery systems, and explain the use of digital health technology for people with diabetes. This is a really big, broad overview of many technical aspects of diabetes care that have been implemented and are being used today in a wide variety of settings. We're going to start with a couple of questions, and I'm going to have you just answer in the chat. And Jose, if you can share those with me as they come up, we'll go from there. So our first question is, insulin pumps and continuous glucose monitors deliver fully automated insulin delivery. True or false? So what are most people thinking here?
We have some responses, and all of them, well, 1, 2, 3, 4, 5 of those who have responded are 6, actually 7 or more are saying that the statement is false.
That is correct. It is false. At this time, most commercially available insulin pumps and CGM systems deliver partially automated insulin delivery, not fully automated insulin delivery. Our second question, insulin pumps and continuous glucose monitors should only be used by people with type 1 diabetes. True or false?
We also have some responses, and everybody is saying that that is a false statement.
Oh, I'm so glad to hear that. That is false. We're using a lot of these devices in persons with type 2 who were previously on injection insulin. Question 3, Medicaid and Medicare don't pay for diabetes technology like pumps, smart pens, or continuous glucose monitors. True or false?
Again, we're having many responses in the chat, and they are saying false.
Oh, wow. I'm so pleased to hear that we're hearing so many correct answers this afternoon. The answer is false. Actually, Medicaid and Medicare do pay for diabetes technology for appropriate patients. Now, there's a little bit of variability with Medicaid state by state, but I think we can make a blanket statement that for the most part, they will cover for appropriate patients. There are many different technologies, and we'll do kind of a 10,000-foot overview of some of these today, and we'll dive in a little bit more with respect to CGM. But we will talk about pumps, CGM, connected smart pens, smart meters, some apps, just some examples of that, some examples of personal devices and trainers. And then I do want to share a little bit with you about open source do-it-yourself systems You may encounter some patients who are using these, and these are patients who are fairly sophisticated because they are building their own pump and CGM systems that are fully automated. So let's start with a brief overview of smart meters, apps, and fitness trackers. Almost every glucose meter that we use presently that are on the market are really what we would call smart meters. They have memory functions. You can enter food, you can enter exercise, you can enter illness. Many of these have these, and a couple of these devices also have subscription services where you can be connected to a diabetes educator, for example, and receive text messages with regard to your data. I don't really favor one meter over the other. I typically prescribe the one that the patient's insurance will pay for, but occasionally we do have a meter that also matches with a pump. So we want to be sure to integrate those, and that sometimes requires an extra step of pre-authorization. But most meters these days are very good. There are FDA guidelines for accuracy, and they all have to follow them. It's really changed a lot over the last decade or so. There's a few apps out there. These are some more common ones, but there are quite a few. And I'm not endorsing any particular app, but MyFitnessPal is one I see used fairly often, one called Glucose Buddy, where it'll track data for you. Then there's a couple of food ones that are actually pretty good, but there are many of these out there as well. And these are easy to find in the App Store on your smartphone. Fitness trackers are also very common, particularly the Apple Watch, which I'm not endorsing. It's just common. Fitbits are still fairly common. I've just given a couple of generic examples here. There are many of these devices with many applications. You've probably seen some that also track things like cardiac data. The big challenge with these right now is getting that data integrated into the electronic health record meaningfully. So that's really the next big step for these types of devices. So let's move on now to continuous glucose monitoring, which is really where most of the action is right now. CGM really comes in two categories. There is the CGM professional, and this is where the CGM device is owned by the clinic and placed on the patient by a healthcare professional to assess 7 to 14 days of blood glucose data. And this collects data every 5 minutes, 24 hours a day, 7 days a week. We often do this for patients with variable blood glucose, difficulty achieving targets, or those considering a pump with or without a CGM. This is a good way for them to try it out and see how they feel about it. The CGM Personal, of course, is owned by the person with diabetes. And again, it tracks data continuously. Some integrate with insulin pumps, but also can be used freestanding, typically with injection insulin. But we do have patients who are on oral agents or maybe a GLP-1 who like to use these too. And if their insurance won't pay, some people actually pay out of pocket for some of these, but I don't see that commonly. There are 3 different CGM systems that are commonly used right now and approved in the United States. One is the Dexcom 6. This does not require any finger stick blood glucose monitoring for calibration. You only do a finger stick if you think something is wrong. It can be worn for up to 10 days. It has a very nice smartphone app, and it uses its own platform called the Clarity platform. This is online cloud-based platform where the patient can actually upload their data into the cloud and then share that with their healthcare provider. And we use this quite a bit. If they don't want to do that, they can bring the device to their appointment and we can download it onto the computer. And they can share their data with up to 10 other people. So friends and important family members who maybe are invested in this. We see this a lot with children and adolescents. There is a new Dexcom right now that just came out, and it combines the sensor and the transmitter into one piece. The 6, that's 2 different pieces, but it's not set up to be linked with any pumps right now, although that is coming. You might see the Freestyle Libre series pretty often. This is one where it has to be scanned over the reader, over the transmitter on the arm, typically. This one can be worn for up to 14 days and also has a nice smartphone app. And it also has its own cloud-based platform, which we use quite a bit in the office. And they can share data with up to 20 people. I'm not sure 20 people would be that invested in my blood sugars, but it is possible with this particular series. And then Medtronic, they have their Guardian Connect as a freestanding device as well. Although we don't use this one quite as much as a freestanding device, we use this one a lot more with the integrated Medtronic pump. And this one does require finger stick blood glucose for calibration 2 times a day, whereas the others don't require that. And it also has a nice app and also can be shared with up to 5 people. I don't want to neglect the implantable CGM, although we're doing very few of these right now. This is the Essentia Eversense E3. It does require some finger stick blood glucose monitoring for calibration, but it can be used for up to 6 months of use, and it has a phone app. So that little small thing that you see there that's maybe an inch long or so, that actually goes under the skin. And then that black piece is a reader that goes right over it. And then that data is transmitted to its own device or to a smartphone. And it also has some alarm systems as well. All of these have high and low alarms, which you can see the benefit for many people would be very good. Typically, when we start a CGM, we see less variability of blood sugars. We typically see an improvement in average and in A1C as well. Many people do quite well with this, and they get invested in it pretty quickly. Let's talk a little bit about devices for insulin delivery. And there are really 3 different categories of devices for insulin delivery at this time. One is the traditional insulin pens, which I'm sure many of you see in your practice, as well as connected or smart insulin pens, which you probably see as well. And then insulin pump, which you might also see referred to as continuous subcutaneous insulin infusion. These are often used with a CGM and sometimes just with finger stick glucose. And there are several different brands of each type of insulin delivery device. These are just some examples of what we call connected insulin pens or smart pens. These are kind of a bridge between traditional insulin pens and a pump. They have a memory. They have some features that pumps have. Pumps typically can tell you approximately how much insulin is still left in your bloodstream, for example. So let's say you do an injection at noon, and 2 hours later, maybe you're going to redose or do a correction dose or something like that. A pump and a smart pen can approximate how much insulin is still left in your body. And that can be used to calculate an appropriate second dose, for example. So these do have memories, they have calculators. Like pumps, they have insulin to carb ratio, they have correction factors. So pretty nifty little devices. They're all very good. They each have various platforms. That's kind of a rapidly changing environment right now. I purposefully did not list all of those at this time because they seem to be adding pretty much continuously. So when you get familiar with a particular device, you're going to want to know what platforms it integrates with. And Eli Lilly, Medtronic, and Novo Nordisk all have devices right now in this particular field. Sensor augmented pumps are older pumps like the Medtronic MiniMed 630G and a Guardian CGM, the Tandem T-Slim X2, which is still a common pump, but with a Basal IQ algorithm to calculate insulin delivery, and a Dexcom 6 CGM, and the now older Omnipod Dash, which is used with a Dexcom 6 CGM. These are not hybrid closed loop pumps. They're not semi-automated pumps, but they do have low glucose suspend and high and low alarms. So they do see if your blood sugar is going to be low soon, it actually will slow down or stop insulin delivery at that time. These are not quite as sophisticated as hybrid closed loops, but there's still a lot of these out there in circulation, and we still encounter patients using these all the time. They do require a little extra attention from the user. They have to manually enter basal rates and use those basal rates. Of course, they have insulin to carb ratio, and they have correction factor, also called the insulin sensitivity factor, to help calculate boluses accurately. And these were widely used pumps for a number of years before hybrid closed loop came out a few years ago. The hybrid closed loop or automated insulin delivery systems do just about everything in controlling insulin delivery except for food boluses. You do need to enter the grams of carb in these devices, but other than that, they do everything. They control the basal insulin, they increase it, they lower it. A couple of them do small correction boluses, but we are on the way to fully closed loops very soon, and I will be talking a little bit more about that. But all the commercially available systems are hybrid closed loop, except for the couple of older ones I just discussed. And there are 3 AID systems currently available in the United States. I'm not presenting these in any particular order. I'm not promoting any particular device. This is the Medtronic MiniMed 770G. This is a tethered insulin pump with a tube and a subcutaneous cannula, and it uses the Medtronic Guardian 3 sensor. A little bit different with this one is it's a Bluetooth connectivity. It will connect to your phone through Bluetooth, but it won't block other devices from also joining Bluetooth. So that's actually a neat feature. Now, this is a hybrid closed loop pump, and it has what's called a predictive control algorithm. It's kind of like an artificial intelligence program that kind of figures out appropriate basals after the wearer has been using it for a few weeks. And it raises and lowers insulin correspondingly with blood glucose values. But you do have to prompt it when you're going to ingest carbohydrate. This one does require a couple of finger sticks a day for calibration. But the phone app is very good. You can't control the pump with the phone app, but it gives you a full display. This one does integrate with the Accu-Check Contour glucose meter. If you do a finger stick, it will automatically transmit that to the pump, and it will hold it and use that for calibration. The Insulet Omnipod 5 is fairly new. It's a tubeless pump, and the pod, that white thing there in front of the display device, actually the whole thing goes on your body. It can go on your abdomen or the back of your arm. It also has a predictive control algorithm, so it's seeing a little bit into the future. And it's a hybrid closed loop option where it kind of learns the user's patterns and kind of sets up basal insulin patterns for the user. However, it's still dependent on the user to enter carbohydrate intake for boluses. And it does have a device manager that looks like a smartphone display, but this one can actually be operated with a compatible smartphone app, which is what I typically see. And the phone app can share with up to 12 people with this device. And the Omnipod 5 works with the Dexcom 6 CGM. That's its paired CGM. The t:slim X2 also pairs with the Dexcom 6, and this also is a semi-automated system. It has a tube and a cannula. As I said, it uses the Dexcom G6 and can share with 10 other people. It has a touch screen, which a lot of people really like because they're used to that with smartphones. It's the hybrid closed loop option, but this one has the additional benefit, as does the Omnipod 5, of giving small correction boluses. It'll go ahead and calculate a correction dose and then give about 60% of that. So it's pretty conservative. It automatically switches to 5 hours of active insulin time on Control-IQ. That's its estimate of how much insulin is still in your body after a bolus or a correction. And this is also, you can also operate this with a compatible smartphone app. So we have 3 devices that are fairly sophisticated, that are hybrid closed loop, or we might think of them as kind of semi-automated devices. Other technology that's interesting and exciting are do-it-yourself loops, which have their open source algorithms that can be downloaded off of the internet. They're not commercially sold and they're not FDA approved. And maybe some of you have encountered some patients using these. We have very few, but these are good for patients who are very proactive, they're very motivated and very tech savvy. You have to use an older pump that you can hack into. The newer pumps don't allow that. You need a CGM that you can connect to it with the open source algorithm. And you also need a small little computer that is in the chain of these devices that helps calculate the doses in the algorithm. So they're fairly sophisticated. These were originally developed by some engineers who had type 1 diabetes, and they didn't want to wait for totally closed loop systems. So these are totally closed loop. They dose appropriately for your food. You don't have to prompt it to how many carbohydrates you're ingesting. Tidepool is a commercial company who has just released their loop system, and it's received FDA clearance. But right now they're finalizing some agreements with the various device manufacturers. So this will be able to link up with a CGM and a pump and deliver a closed loop experience, not the hybrid closed loop. The hybrid closed loop, you have to tell it that you're eating. With a complete closed loop like these, you won't have to do that. So this is going to be very cool. I anticipate that this will all be set up and out by the end of the year. American Diabetes Association has their big meeting in June. I expect there'll be a lot of buzz around this at that meeting. So this will be very interesting to see which device manufacturers they actually contract with. So stay tuned for that. So just kind of basic, for those of you who may not know, how does basal-bolus insulin work with a pump? Well, pumps only use rapid-acting insulin. You don't need to inject any basal insulin. It does more than just give corrections and food doses. For basal coverage, that's actually small pulses of rapid-acting insulin released every few minutes. And in the hybrid closed-loop systems, every 5 minutes, the pump and the CGM are making a decision about how big that tiny bolus should be. And larger amounts are released for mealtime and correction doses based on pre-programmed and user-entered data. So there are various ways to calculate an insulin to carb ratio and a correction factor or an insulin sensitivity factor. Basically, for most people who have type 1, who maybe are not overweight or obese and are insulin sensitive, they might only need 1 unit per 15 grams of carb for their bolus calculation. And for their correction bolus, it might be 1 unit to drop an elevated blood sugar 40 to 50 points. For somebody with type 2 who's overweight, who's more insulin resistance, it might be more like 1 unit to 10 gram of carbohydrate or 1 unit to 5 gram of carbohydrate for the food calculation, and maybe 1 to 20 or 1 to 30 for a correction dose. So let's say at the time that you're going to eat, your blood sugar is 200 and your target is 100, and your bolus is 1 to 15 gram and your correction is 1 to 50. So it calculates the food bolus, and then it also adds on that correction bolus to help you get to the target of 100. And it puts those together and puts those out as a bolus for your food. These things are really little computers. We program all of this stuff with the patient. There are some formulas that you can use to calculate this, like the rule of 500 or the rule of 1800. We could spend a lot of time on this. I just want you to be aware of them. And then the calculator, as I mentioned earlier, also accounts for insulin on board, or estimated remaining active insulin, which keeps the patient from stacking boluses and having a late hypoglycemic episode. These AID systems handle basal insulin management automatically. They take a couple of weeks or so to really learn the user. And then about 50% of the total daily dose should be basal, and about 50% should be total bolus. That's variable. For high-end athletes, I work in a university town. They maybe don't need as much basal insulin, but maybe they're eating really large meals because they're eating 10,000 calories a day. So there are some variability with different types of patients. So let's walk through a little bit continuous glucose monitor data for clinical decision-making. All of these devices have proprietary platforms to upload or download their data. Dexcom has the Clarity Cloud, Medtronic has CareLink, and t:slim has t:connect. All have similar data reports. They are standardized, the information that you get, but the way that they look is a little bit different. I don't really have a preference. I think they're all very good. I do a lot of telehealth. I live in a very rural part of the United States. I have some patients who live 200 or 300 miles away from me. And if they can upload their data to the proprietary cloud platform, we can actually view it together during their appointment. This is really important in telehealth. Patients can also just call me or message me through the electronic health record and say, could you look at my data? I'm having this problem. Or I'm sick, my blood sugars are not ideal. Can you help me with this? And then there are some non-device specific platforms. For example, you saw that Omnipod doesn't have a particular platform. They use Gluco, which is not tied to any particular device. And then Tidepool can be used with a number of these as well. That'll probably be more important when their closed loop algorithm comes out. Well, it's out when it gets programmed for various devices. These are some of the multi-system download platforms. In your office, you can get these set up. Usually we have this set up on a single computer in different areas of the clinic. And you actually plug the device into the computer, it downloads all the data, creates a data package for the user to look at. And I'll go over some basics with this, but all of these devices can be either uploaded to the cloud, or when the patient comes into the clinic, we can download it onto a computer. This is what's called the ambulatory glucose profile, and this is kind of the heart of the data set that you get. You can get daily data. You can also calculate some other features with this, but this is the stuff that it's kind of been agreed upon by a consensus committee that this is what we should be looking at with every patient using a CGM. Now, it's tempting to look at the line graph, the up and down there that's blue and black, but actually you want to look at the bar graph first. And we can see that with this particular person with diabetes, 20% of their blood sugars are over 250. 23% of their blood sugars are between 180 and 250. And the time in range is 47%. Time in range is defined as 70 to 80. If you have a 70% time in target range between 70 and 180, that translates into an A1C of about 7. The other issue this person is having is some lows, particularly very low. Low is less than 70, that's 4%. That's a fair amount, but 6% less than 54 is quite a bit. You can also see in the panel immediately to the left there that this person wore it for 13 out of 14 days, which is over 90% of the time. And then it gives you the ranges there that you need to know. So below 70 should be less than 4%. As I mentioned, time in range, 70 to 180 should be 70%. And time over 250 should be less than 5%. You can see it also calculates an average, in this instance, 173. And the GMI is a predicted A1C, but it's calculated different than A1C. That'd be 7.6 here. This person has a lot of variability, though. The coefficient of variation is almost 50%. That should be less than 36%. And you can see in the line graphs below that, the daily profiles, there's a lot of up and down with this person, which we would expect with the very high readings and the very low readings. What I see here is somebody who's having some lows very early in the morning after about 3 a.m. And then they're having a peak probably after their breakfast and another peak probably after their evening meal. So we would want to address those mealtime elevations while also trying to fix the overnight lows. So that's usually just some kind of medication change. In this instance, we might want to add or change a medication that addresses post-meal blood sugars, like maybe rapid-acting insulin, or a GLP-1 or an SGLT2. The overnight, if this person was on basal insulin, we'd probably want to decrease that a little bit. Or if they were taking a large correction bolus at bedtime, that might be producing the low. So there's some different scenarios we would have to work through. And the more of these you do, the better you'll get. It's just a matter of building experience. This is the International Consensus Panel recommendations. And I noted the far one on the left is the typical one for your usual type 1 and type 2 patient. For older or high-risk individuals, you want to remember that we're customizing A1Cs for those people with diabetes. And their target A1C may not be less than 7. It might be less than 7.5 or less than 8. That would translate into a time in range of 50%. And that's entirely appropriate. But you'll notice that we're really focusing on avoiding hypoglycemia in somebody like this who might be more frail, more high risk, multiple complications, multiple comorbid conditions, or maybe hypoglycemia unawareness. And then there are different guidelines for pregnancy. Now you can see on the pregnancy for type 1, it says 70%, but look, the target range is different. The target range is between 63 and 140. So they need to have a bulk of their blood sugars between 63 and 140. Now you can see we're willing to tolerate some hypoglycemia here, but it's the same as it is for a typical type 1 or type 2. And then persons who have gestational or maybe type 2, that might be a little tighter. Persons with gestational are going to have their diabetes over a very short time window. So we really have to work that time window to make sure things go well. And persons with type 2, they tend to have blood sugars that maybe are a little bit more stable than somebody on type 1, although we're seeing less and less of that with sophisticated devices like we've already discussed today. So who should have a pump and or a sensor or CGM? CGMs right now can be for any type 1 or type 2 on insulin. We do have some type 2s who maybe will seek these out on their own, but of course there's a cost factor with that. But right now, for the most part, coverage works for those who are on insulin. A pump would generally be reserved for a type 1 or a type 2 on multiple daily injections who wants to do something different or that's not working for them. This should always be shared decision-making. And there's a lot of detail that goes into selection of the person and selection of the device. And the American Diabetes Association Standards of Care has an entire section devoted to this. We could probably spend 30 minutes discussing appropriate persons with diabetes for different devices. But the take-home message here is shared decision-making. It's important not to get biases toward a particular device. What we do is we have the person see the diabetes educator who then reviews the features of all of the common devices and helps the person with diabetes make an appropriate choice for them. So maybe they're on basal insulin and maybe metformin and maybe a sulfonylurea or some other agent. Maybe a Freestyle Libre would be good for them, or maybe a Dexcom would be good for them. But they can only make that decision if they know what the features are and how they work. And that's a critical piece for these devices for anybody. In my practice, I generally use devices for people who are not meeting goals on multiple daily injections with type 1 diabetes, and some with type 2 on basal or multiple daily injections. Patients who are good with follow-up seem to do better with these devices, but not always. Occasionally, I'll really jumpstart somebody after they have some success with technology. And that might just be after wearing a CGM Pro for 10 days. That really lights a fire under some people. And they really feel good about what they're doing. They feel like it's a good next step. And it used to be that we thought that persons like that maybe would not do well. But our experience over time has shown us that this can really help some people get a leg up and feel good about what they're doing. People with a lot of blood glucose variability also usually benefit from at least a CGM. And people with asymptomatic hypoglycemia, they do really well with CGMs because they have low alarms. So how do we get started? Well, think about who is on your team. Of course, there's the primary diabetes provider. That could be an advanced practice nurse, physician assistant, a physician. We see more and more input from our pharmacist, which is very important. Of course, a nurse or a medical assistant. If you have a diabetes care and education specialist and a nutritionist, and then others, of course, that you're aware of, like behavioral health or social worker. But not every practice will have these team members. We need to think about how we're going to divide up the workload and divide up the duties so that we can be efficient with the use of devices. So get the necessary technology for your practice. This is kind of a busy slide, but in summary, what I recommend is pick one that you can get familiar with, like maybe you decide you're going to do a lot of freestyle Libres. Just to start, pick a few patients to get going with that, a CGM Pro, for example, and just get some practice with it. And the more you do with these, the more efficient you'll get, and the more comfortable you will be adding other devices. You know, maybe you'll go on to add the Dexcom, or maybe you'll have a few patients who would do well with a pump. But it's just a matter of, you don't have to throw a switch and do everything all at once. Just find one, get familiar with it. All of the major device manufacturers have software that can be installed on an in-house computer. As I mentioned, it can be uploaded to their cloud or downloaded into the medical record. And your IT people can probably help you with this as well. My experience is that the reps for these companies are very helpful in getting these set up in our office. So if you have any contact like that, that's a really good way to go. But once you've done a few of these and develop a routine, the flow is really good. And I published an article in Diabetes Spectrum a little over a year ago that really goes over this in detail. And I would encourage you to look at that. What I usually do as well is I don't wait for the data to be downloaded before I start seeing the patient. I start the patient visit, and then the nurse brings me the data after we've been visiting for 5 or 10 minutes, and then we can go over their blood sugars. So you can get a lot done in that 5 or 10 minutes. You're not running behind waiting for data to be downloaded, and that can really help your efficiency as well. Interpreting CGM can be billed, and many third-party payers cover these services. It's a charge code of 95251, and whoever helps you with your business office, your coding, or your electronic medical record is probably already familiar with this or can be easily. And this is the only thing that they really need to get started. And then there's the ambulatory glucose profile. Remember that slide I showed you with the line graphs and the bar graphs? I actually do a screenshot of that and paste it into the electronic medical record because it contains all of this information. And then I can do a 1 or 2 sentence interpretation. Average is high, GMI seems to be elevated. Looks like there's a lot of post-meal elevation and overnight lows. Suggest this, and that's it, you're done. Medicare has coverage requirements that have actually gotten a little bit more open-ended recently for CGM. They need to have a diagnosis of diabetes, of course, and be treated with insulin. And you need this phrase, require frequent adjustments of the insulin treatment regimen, which is typical for people on multiple daily injections. If they're doing carb counting, their dose for every meal might be different. And they've been seen in your office within the last 6 months and will be seen every 6 months going forward. If they don't doing that, Medicare stops paying. I would also say keep an eye on that because that may be another shifting area of payment coverage. I anticipate it's just going to get better and better. So let's do a quick case. This is Maria. She's had type 2 for 8 years. She has hypertension and dyslipidemia, which of course is part of diabetes for most adults. She has albuminuria and had a history of a TIA. So she has microvascular complications and macrovascular complications. She has chronic kidney disease, but her GFR is okay for just about every medicine we'd want to use. BMI is 30 and her A1C is 8.5. She's noting what she feels are lows, sometimes midday or overnight. She's appropriately on a statin. She is on an ACE. She's on aspirin as she had a cardiovascular event. She's on high-dose metformin and a sulfonylurea, and she happens to be on basal insulin. So now that we've thought about this a little bit and talked about different parameters from CGMs, which of these metrics is thought to be at least as important as an A1C? Actually, it's all of them. Although time in range is thought to be kind of the secondary A1C at this time. So all of these are important, but more and more you're going to see time in range being treated almost on equal footing with an A1C. That doesn't mean we don't do A1Cs anymore. Remember, time in range is only for a couple of weeks or maybe a month, whereas A1C is 3 months worth of data. But this is a really important piece at this time. We also want to individualize A1Cs, and there's factors to consider like the support system, complications, comorbidities, life expectancy, diabetes duration, and risks with hypoglycemia. Typically, somebody with macrovascular disease, we really want to avoid lows. So maybe an A1C of less than 6.5 or less than 7 is not appropriate for this particular person. We can see here that she has some blood sugars over 250, and she's also got a few lows, but not very many. Her predicted GMI is 7.7, and her overall average is just high. She doesn't have a ton of variability, not a lot of post-meal elevations, although a few you can see in the daily profiles below with the yellow. So would this person be a good CGM candidate? I think she might be. Although her A1C might be acceptable, she wouldn't have to do finger sticks anymore. She is on basal insulin, so she probably would qualify. And I think I would consider that with her, to maybe get her in time in range a little bit more, but also maybe to cut out those lows. Often we see people going on CGMs and their lows usually become quite infrequent. So what's going on with her? Well, she has an elevated A1C with occasional lows. She has some things that are concerning, which include complications. And we might want to think about maybe a medication that would be more appropriate for somebody with cardiovascular disease. She's not on a GLP-1 or an SGLT2. If we started either of those, we could probably stop the sulfonylurea. It wouldn't just be addition of medication. Remember that those with cardiovascular disease, if they have appropriate kidney function, should probably be on an SGLT2 or a GLP-1. So that might help us as well, and probably would not add a lot to her having hypoglycemia, especially if we stop the sulfonylurea. If we did that and she had some lows, we would just lower her basal insulin dose. Just a few words about telehealth before we wrap up. Essential equipment for success, of course, is a good video source and camera with good quality. The lighting in the room is very important. If you're sitting in a shadow, that's really distracting for the patient. You need to have quality internet. I've been doing telehealth for about 10 years. And in North Dakota, there's been a huge push to get high quality internet statewide. So I rarely encounter a patient right now with poor quality internet. It's been a very successful thing in our very geographic disparate state. You want to have a backup communication in case your video goes down, you can at least talk on the phone. And the person, of course, needs some kind of device, but it can just be a phone. They don't need a laptop or a desktop or an iPad. It can just be a phone. And we also do facility-to-facility telemedicine. So there's really two different kinds. There's a virtual visit, which is device to device, and usually the patient's at home, but sometimes they're at work, they close the door in their office. I've done visits with persons out in the field driving their combine for wheat harvest. That's all safe because it's GPS controlled, but you can see I can deliver care about anywhere. They don't need to come and see me if they live a long way away. Facility to facility is where they go into a clinic at a remote site, and I'm either in my home or at my clinic. And that's really neat because we have electronic stethoscopes. The nurse or the medical assistant can help with a foot exam. So that's really slick. And those really look a lot like traditional clinic visits. So at the remote site, they check in, they get their vitals. It's pretty much just like any other clinic visit, and the charting is virtually identical. Video visits, the patient checks in electronically. I try to get them to weigh themselves and get a blood pressure if possible. And if they have other devices, I really like them to upload it to the cloud so I can see it. For the facility-to-facility visit, if they come in and they haven't done that, they can download it on their computer and put it in the medical record. This is kind of what my view looks like, except the patient would be facing me. I prefer a split screen, although you can put this across 2 screens if you want. I don't like that because then when I'm looking away at the other screen, I'm not looking at the patient anymore. Where here I can be looking at their chart, you can see that in the middle, and their AGP report on the right, and really just not be looking away from the camera really very much at all. And that really helps keeps patients engaged. So there are some gaps. Not all healthcare personnel are familiar with these devices, but like I said, pick one, get familiar with it. That's a good place to start. ADA has spent a lot of time trying to develop resources for this. Also, who does telehealth that maybe you can link up with? I just happened to stumble across a clinic that was looking for some diabetes care, and they were willing to do some telehealth, and that's 150 miles away from me. And I have some patients who drive 50 miles to get there to be seen. Also, are you using community healthcare workers? Maybe they could be familiarized with the devices. And it doesn't have to be all or none. Just pick a spot that you think might work for you and do that. We do see a lot of coverage. Occasionally, we will see a payer that says, oh, no, you have to use this CGM. That's fine. We just prescribe that. There are provider biases, of course. There's other social determinants of health just that belong to diabetes care. But who can make the leap in your practice? Think about patients that might do well with this and learn how to do a CGM Pro, put it on a couple of people, see how that works. Diabetes care really addresses the needs of the whole person. And be aware that coverage does exist. It's really disappointing that we might actually be seeing increasing disparities with the use of technology because they're not being offered appropriately to everybody when they really should be. And where I live, there's a lot of geographic disparities. ADA has some very specific and in-depth psychosocial care guidelines. I'm not going to read these to you. I would encourage you to look at them. And this is my contact information. I also have a diabetes professional page where I share diabetes news, some of my own diabetes stories, some discussions about different devices and how to use them. And it's just Eric L. Johnson, MD, North Dakota Diabetes. Almost everything I've talked about today comes from the American Diabetes Association Standards of Medical Care 2023. And I thank you for your attention today.
Thank you, Dr. Johnson, for this great presentation. We are going to ask the people participating in this activity for any questions. So if you have any question for Dr. Johnson, you can either use the Q&A box, the chat box, or if you would like to ask a question verbally, we can unmute your line.
I have put my email address in the chat box as well.
Thank you so much. So if you also would like to get in contact with Dr. Johnson, he graciously added his email address in the chat box. Again, if you have any questions, please feel free to ask your question. In the meantime, please don't forget to complete this survey after you jump off of this webinar. Your feedback is very important for us. And if you have any questions regarding the presentation or the materials, all these will be sent to all participants in the next 2 or 3 days, or you can also visit our website at www.nchph.org, where you can find this recording and also other training and technical assistance activities that we have done or that we have about, or that we are going to provide to all health centers in the next few days.
Jose, I think the only thing I would like to add is if you're not sure if you want to get to the CGM part right now, get some practice with downloading meters. That's a pretty good way to go. That's very easy. And that's something that maybe you can build on to maybe take the next step to a CGM.
Excellent. That's a great that's great information, Dr. Johnson. Also, Dr. Johnson, let's see whether we can get a question from our audience, but I do have a question for you, and this is regarding the population the health centers serve. And one of the biggest concerns sometimes with this new technology is the health literacy piece and the computer literacy.
Yes.
So any recommendation? I went over your slides, and you said that we need to get familiar with some of these devices, and we can train diabetes educators or even CHWs to do this kind of training. But is there a recommendation that you can offer in regards to health literacy and computer literacy?
I think that's going to be kind of hand in hand with you becoming more comfortable and getting familiar with devices. Because the better your knowledge is, the better you're going to be able to transmit that. Now, I'm not saying a CGM is appropriate for everybody, but I think it's a rapidly expanding area. And I think it goes along with just a general push for health literacy and numeracy and familiarity within the community. And once you start getting a few people out there, it's amazing how this can build. You know, here, my greatest disparities are geographic, and we have a large American Indian population in North Dakota. And we've really tried to make some strides in those areas, and with some success to get better with that. But you get a highly motivated diabetes educator, a highly motivated provider, a highly motivated nurse who can spend time with these different types of patients. Again, you know, you don't have to do everything all at once. You don't have to throw a switch and do everything. Pick a few people who you think might do well and work with them and build your own skills.
Thank you so much for that. And Fide, do you see any questions?
Nope, no questions at the moment.
Well, I hope this was worthwhile for everybody today. I think it's a good topic, and I really appreciate being asked to present today.
Thank you, Dr. Johnson, for sharing your experience. And again, if you have any questions, or if you are trying to reach out to Dr. Johnson, he added his email address to the chat box. And again, if you have any other questions, that we can also send the questions to Dr. Johnson. So thank you all for participating today, and thank you, Dr. Johnson, for your time.
Thank you. Have a great afternoon.
Thank you.